We shall now go on to our next speaker, Dr. AKRUTI Desai, who's a consultant in ophthalmic plastic surgery practicing in Mumbai and a product of the very famous LV Prasad Institute. And she's going to tell us on anesthesia in DCR, a very important topic. On to you.
Dr. AKRUTI is speaking on anesthesia and DCR. And
yes, good evening, everybody. Apologies about the connection issue that time. My topic for today is anesthesia in DCR. Yeah. So we all know as ophthalmology residents, we see a lot of students who are scared of DCR. They cringe at the thought of DCR. And so it's painful not just for patients, but it's considered painful for the residents themselves or as ophthalmologists. So a quick overview of the nerve supply of the lacrimal region. We have the infratrochlear nerve, which is the branch of nasociliary. We have the infraorbital nerve, which is the branch of the second division of the fifth nerve, that is the maxillary nerve. So these are the areas, nerves that primarily supply, along with the anterior ethmoidal nerve, which is again a branch of the intratrochlear, which supply the lacrimal sac area. So these nerves need to be blocked while you proceed for the DCR in local anesthesia. But the eternal question always remains whether GA or LA. Historically, local anesthesia has been practiced long back in the 19th century, but current gold standard is general anesthesia, since it eliminates pain as well as elevates the anxiety associated with passage through the bone, especially while making the ostium. Although in elderly patients or patients with comorbidities, GA can be avoided. Also, personally, in revision DCR cases, I prefer general anesthesia because of the scar tissue. The spread of local anesthetic is not very smooth. There are various pain scales, at least 10 to 11, but commonly they involve either the numerical rating or visual analog scales, wherein you can select a picture which matches your pain level and tells how severe your pain is, or categorical scales which use words along with numbers, colors, or in general location on your body. So this is a diagrammatic picture of how you can ask the patient how severe was their pain during surgery, and then moderate your technique accordingly. So preoperative nasal endoscopic evaluation is done in all patients, and a topical anesthetic spray of 10% xylocaine or lignocaine is used, just 1 to 2 puffs before performing evaluation prior to planning DCR surgery. If we are going ahead with local anesthesia, then first we start with topical anesthesia, drop of topical proparacaine in the conjunctival cul-de-sac. The nasal mucosa can be sprayed with 10% xylocaine, and packing is done with 4% lignocaine and 0.5% or 0.04% xylometazoline. Infiltration anesthesia includes 2% lignocaine with 0.5% bupivacaine, or with or without adrenaline. And in external DCR, we can infiltrate it after making the ostium, in addition, so that we have better hemostasis while going, making the nasal flap. Coming to the role of adrenaline, let me go here, there are various formulations available. There is xylocaine without adrenaline. There is lidocaine with adrenaline, which is 1 in 80,000, or 1 in 1 lakh, or 1 in 2 lakhs. So it's important for any one of us to deduce how much of adrenaline is there in each quantity, in each of the solutions that we prepare. So in the 1 in 80,000 in 1 ml has 1.25 milligram of adrenaline, while in 1 in 2 lakh, which is this vial, has just 0.05 milligram in 1 ml. So it may not be as effective if we are using this solution for DCRs. I personally use 1 in 1,000 adrenaline 1 ml 2 vials in a 30 ml plain lidocaine for my anesthesia in DCR. So 1 in 1000 comes to 1 milligram per ml. The technique of nasal packing is very vital. We direct superiorly and backwards. If we go along the floor, then we might end up in the inferior meatus. So our end goal is to locate our nasal pack in the middle meatus, which is going to be the site of future ostium. I'll just play a short video. I'm sorry, it's not playing.
You can just minimize your presentation and play separately, AKRUTI.
Maybe you should move on to the next slide.
Okay, fine. Yeah, 1 second. It's
Ma'am, you can stop and reshare.
okay. In the interest of time, I'll move on to the next slide. Yeah, it's begun. So I first mark the incision which I'm planning.
You need to stop and reshare. The slide is stuck. Just stop the share and then reshare.
Is it okay now?
Yeah.
Perfect. We can see the video now.
Okay.
It's again stuck.
Okay, so I'll just explain. I mark a subciliary incision with a skin marker and then mark out the infra orbital nerve at this location where it exits from the orbit, and also palpate with the non-dominant hand this supraorbital notch. And 26 gauge needle with a 2 cc syringe or syringe even to inject in the medial to the supraorbital notch, so that there is anesthesia of the infratrochlear nerve. Apart from that, the third injection is given locally over the anterior lacrimal crest and infiltrated subcutaneously inferiorly as well as superiorly to anesthetize the lacrimal sac region.
Some problem there. Poor network, Mr. Sunil.
Yeah, I think she's resharing it.
Yeah.
You can move to the next slide.
Move to the next slide. Yeah.
Also to remember for pediatric DCRs is obviously we would go ahead with general anesthesia. Adequate decongestion is needed, and we have to consult with anesthetists like in all GA, but more so for pediatric cases because they are more sensitive. We have to note that while nasal packing, the nasal cavities are narrower, and also there is a lower skull base in pediatric patients. So these are the factors. If you do it too forcefully, you might perforate the cribriform while inserting your nasal pack. In endoscopic DCRs, definitely general anesthesia is what I have done. I prefer to use.
1 minute left.
Okay, neuropathy is about 2 ml of normal saline with 1 in 1000 adrenaline or Vexel sponges. Infiltration of lateral wall and medial turbinate with 2% xylocaine with 1 in 80,000 adrenaline. The area to infiltrate is the maxillary line as seen endoscopically, what you can see here where the needle is being inserted. and the middle turbinate, so that the mucosa shrinks and it gives you more space to start your endoscopic DCR. Total intravenous anesthesia is with propofol and remifentanil. It helps reduce the blood pressure to about 60 to 75 millimeters of mercury, and thereby helps reduce intraoperative bleeding, which eventually tells how the outcome would be. This is an interesting article which I would recommend. Role of anesthesia in endoscopic and external DCR. They have studied multiple cases. Dr. Javed Ali has been an author on this, and they've concluded that endoscopic DCR with general anesthesia is definitely should be the solution of choice. However, local anesthesia associated with sedation can be used as an alternative in selected cases. But for external DCR, there's lack of data, so there were no meaningful conclusions regarding choice. Thank you very much. And I'm sorry about the connectivity issue.
No, thank you very much, Dr. AKRUTI. You did try to convey, and we lost out on that wonderful video teaching you would have done. On to you, Dr. Arvind.
Thank you, Dr. AKRUTI, for bringing out all these aspects. My question is to Dr. Lakshmi Mahesh. Despite so many DCRs, madam, I'm sure you would have seen that some people have excellent pain threshold and some people seem to be very afraid of undergoing a DCR under local anesthesia. Do you have a way of judging who should be given a little more attention? Would you prefer general anesthesia for your majority of your cases? What would
General anesthesia, thanks Arvind. General anesthesia definitely for endoscopic DCR, but once you start getting a lot of experience in endoscopic DCR, you could get away with local, because the main problem in endoscopic DCR is the menace reflex. Every time the scope is coming right in front of your eye. Now for external DCR, my preferred choice, if the patient is not a pediatric patient, it's only local anesthesia with very good sedation. I give 6 hours of fasting for sedation, and I also get an anesthetic assessment done. So we really knock them off, and I would like to have BP on the lower side. I don't even inject anesthesia unless the BP is below 120. 130 is like the maximum cutoff. Above 130, I don't even go and put in. Now, she was talking about anesthesia. Sometime in 1995-96, Jeffrey J. Hurwitz, who was recently passed away, I think a few years back, he lacrimal surgeon in Toronto, brought about a beautiful textbook of lacrimal surgery, where he described about the 3-point anesthesia. I think all the youngsters should read. And it was written by none other than a Tamil anesthetist, Dr. Chidambaram. I think he has contributed to that chapter, a 3-point anesthesia. Now, I follow that technique religiously ever since I read that. In addition, I give a little more because the ethmoid bone needs very good, because every time the sac is well taken care of, when you start punching the bone, the patient starts wincing. So between the sac and the medial wall, you should give a good infiltration. You can use your 23 gauge 1.5 inch needle, but you have to be worried about the anterior ethmoidal artery, which is exactly around 24 millimeters from the surface. So I just use the 26 gauge needle, and you won't believe me, I give a 50% dilution. 1 in 200,000 adrenaline. Xylocaine, 2% xylocaine with adrenaline, 1 in 200,000 with Hyalase, with 50% dilution, almost 12 ml of anesthesia gives a 3-point anesthesia. One is along the nasociliary, that is the curvilineal line. I don't believe in that subciliary incision. Then the second is a little bit you can give in to the trochlea for some amount of anesthesia, again along the line of incision. Then the para-infraorbital block. Not exactly infraorbital, you keep it in that direction, but aim it towards the sac. It's or para or peri-infraorbital. And then the last one is, I have modified that over the last 20-30 years, between the sac and the medial wall. Give good infiltration. Small needle is enough. 2 cc syringe. With 5 cc syringe, you'll have a lot of resistance. These are all the tiny tips, and good sedation. And of course, after giving the anesthesia, give your nasal pack. Make sure you have Otrivin nasal pack. If you want, you can dip it in few drops of adrenaline. ENT surgeons are very bold. They just empty the adrenaline and pour into the cup. We are not like that because we are worried about all the tachycardias. Just put 1 drop in 10 ml of saline. It works wonders.
Wonderful.
Thank you, madam.
Yeah, can I add
Yes,
something?
Dr. Shreya,
Yeah.
please.
Yeah, I totally agree with ma'am, because I'm also following the same thing. You little bit inject in the periosteum and then you don't have to inject much. You can do very well surgeries with small anesthesia. And what she talked about the pediatric anesthesia nowadays, if you use sevoflurane, it is a wonderful anesthesia. Anesthetists are using that within 5 minutes you can even suction and everything is very easy with that anesthesia, or laryngeal airway mask. These two are the safest anesthesia techniques for, especially for pediatric
Please,
lacrimal
for
surgery.
pediatric cases, don't go without intubation. You need to
Yes.
have intubation, because if you're giving syringing or other, even laryngeal mask is not such safe. So you
Yeah,
have
but
a
if
complete
you do with
intubation because
sevoflurane, it's okay. Because they are putting additional airway in the intubation.
still, I would say that intubation is
Yeah.
better. Yes.
Yeah.
And Dr. Ayan Sundarraj, the grand old anesthetist in Shankar Netralaya, he had told me for all oculoplastic surgeries, we used to have a 15-degree elevation of the table for that is for minimizing bleeding. But for DCR, the endoscope, that is for probing and syringing alone, he used to give 15-degree depression, so that whatever collects for the pediatric case, it collects down and you can just suck it out,
Oh, good. Nice. Any other opinion before we go on to our next speaker?
I would just like to mention that right now, with the recent court verdict, anesthesia and especially for pediatric age group, it's a very burning topic. And I think all of them should be evaluated properly. And even though the anesthetist is involved, it's a huge responsibility on us for the child or the patient to have a good outcome. Dr. Javed, I'll just quickly drop a question, because I know you are very liberal with using adrenaline in your nasal packs. Can you just give us a guideline?
Probably because I have a rhinology background.
Yes.
Maybe that might be the reason. We're not scared. I usually use 1 in 10,000 for endoscopic DCS, and 1 in 10,000 has usually helped me out. So I think it's more about comfort, what Shreya was talking about or what Dr. Lakshmi was talking about. I think it's about your comfort, and as long as you can deliver it, and the settings matter. Like we have 15 anesthetists walking around us in LV Prasad. We don't really have to worry about anything, in terms of general anesthesia. For the smallest things, we can take them under general anesthesia and do that right away. But that may not be the case with the people working in different setups. So I think based on that and how comfortable your anesthetists are, and how well you also train your anesthetists to be comfortable with higher concentration of adrenaline, I think all those things are very individualistic.
Thank you, Dr. Javed.